Department of State in 2018. This program provides community leaders from all around the world with an intensive professional development exchange program in the US. As a CSP fellow, Dr. Collins has done a tremendous job engaging in community outreach to marginalized groups in Malaysia since his return. We are lucky to have these experts with us this evening and today, this morning in Malaysia, and we are in for an engaging and interesting discussion. Without further ado, I will hand the session over to our moderator to start us off. Over to you, Dr. Collins.
Thank you, Catherine, for the wonderful introduction. I'm really excited to be here moderating this session today with two renowned speakers who are experts in the field of infectious diseases, Prof Adeeba and Prof Altice. Before we jump right in, for those of you who are joining us live on Facebook, we are accepting questions. And so as the talk progresses, if you have any questions that you would like It is one of the few dedicated HIV research centers in the region. She's also a Yale affiliated faculty member since 2012. In fact, next month, Professor Adeeba will be appointed as the president for the International AIDS Society, making her the first Asian to head the IAS. Congratulations on the appointment, Professor. This is really exciting news. Our second speaker for today is Professor Altice, who is joining us all the way from Yale University in Connecticut. And I understand it's late in the evening there. So thank you so much, Professor, for taking time off your busy schedule to join us to talk a little bit about the coronavirus and its impact on our lives. Prof Altice is a professor of medicine and epidemiology and public health at the Yale University School of Medicine and School of Public Health. He is also a clinician, a clinical epidemiologist, and an intervention and implementation science researcher. I understand that Prof Altice is familiar with Malaysia as he has been working with Ceria as well as Prof Adeeba for many years now. Thank you once again for all of you for joining us. I would now like to invite Prof Adeeba to begin the session. I believe she will be starting off by talking a little bit about the coronavirus, its disease presentation, and the situation here in Malaysia. Prof Adeeba, over to you.
Thank you very much, Collins, and good morning, everyone. Just give me a few minutes to share my slides. Hafizul, you might need to do this for me. My computer seems to be... Could you share the slides, please, Hafizul? Collins, we'll need to get Hafizul to share the slides for us. Okay, thank you very much. Let me begin by thanking the US Embassy for inviting me and Rick Altice to give you an update on the COVID-19 situation, both globally, locally, as well as some clinical updates and the race towards finding a vaccine. As you know, the world has literally been turned upside down by the novel coronavirus, which has subsequently been renamed SARS-CoV-2 virus. This is the third of the really human coronaviruses that have created such devastating clinical illnesses. The first, of course, being the first recognized SARS in 2002 that affected slightly over 8,000 people and led to 774 deaths. A few years later, well, about a decade later, we then came to hear about the MERS-CoV virus that although resulted in fewer cases, but the mortality rate from MERS was much higher. And now we are living with a major pandemic caused by the SARS-CoV-2. We have over 4 million people now infected with many more, hundreds of thousands deaths resulting from it. Next slide, please, Hafizul. This is the a very up-to-date and very useful website from the Johns Hopkins University that gives us real-time epidemiology from all over the world. As you can see on the left-hand side of the screen, this is from late last night. We now have close to 5 million, 4.9 million or close to 5 million confirmed cases. Of course, there are many, many more that have not been diagnosed or identified. 324,000 deaths as of yesterday evening. What about the situation in Malaysia? Next slide. So Malaysia, as of yesterday again, has had 6,941 cases, and in terms of deaths, we have had, we've done well and have had just over 113 deaths reported to the Ministry of Health. As many of you who are living in Malaysia will know, we first had cases reported from foreigners or visitors into Malaysia. This is this orange bubble here. And following institution of intense screening and contact tracing, we really had low numbers of cases in the beginning, in January, until an unfortunate incident of mass gathering, which resulted in the first large cluster, which has since evolved into many more mini clusters and have been responsible for the bulk of infections in Malaysia. With the introduction of that public cluster, as it got known, the Malaysian government instituted the movement control order, and which then led to some flattening of the curve as was desired. However, this didn't really lead to major reduction, and there were subsequently other clusters that emerged, which then prompted the government to introduce further restrictions in movement. That seemed to have led to further flattening, and now the daily reported cases in Malaysia have settled to less than 100 new cases per day. We continue to see clusters, small clusters. At the moment, it seems to center around foreign workers. Next slide, please. So if the aim of the movement restriction or lockdown or MCO or whatever you want to call it was to flatten the curve, the question is, has Malaysia achieved that? And I believe if you look at this graph from our World in Data that also collects data in real time, you can see that we've been quite successful in bending the curve. Although I think ultimately to get to zero will be a tall order, but safe to say that from where we were about 8 weeks ago, I think we can be safe to say that we have somewhat flattened or bent the curve. Next slide. The one thing that we've learned about the COVID-19 pandemic is the huge heterogeneity of the pandemic. The level of infections, the prevalence, the incidence, the mortality rate can differ hugely from country to country, and even from states to state, and even if you narrow it down from counties to counties. So it is very difficult to compare one country from another because there are differences, obviously, in the timing of the institution of prevention measures, and again, the heterogeneity in what prevention measures are taken when. So I show you, because we're talking with colleagues from the United States, where the US is in terms of bending the curve. I think everyone is aware that the cases in the US really, unlike Malaysia, only emerged in March. And again, in the US, there are different scenarios. And for instance, in New York City, they seem to have bent the curve, but in other states, it has flattened. So overall, it appears that in the US, it's somewhat flattening, but probably has not gone into the downward trajectory yet. Next slide. So just quickly on what this bending the curve and flattening the curve is all about. I think it is very, very important to remember the original modeling from colleagues from the Imperial College around the lockdowns and the non-pharmaceutical interventions that needed to be taken for the COVID-19 epidemic to contain the epidemic. And the primary reason for lockdowns and the strict movement restriction was to give the healthcare system breathing room to prepare so that it doesn't get overwhelmed by having many, many people becoming infected at the same time. And if you follow that principle, I think in Malaysia, the lockdown and the MCO seems to have achieved its primary aim, which is to allow the health system to prepare to ensure that our health system and capacity wasn't overwhelmed by having so many patients infected at the same time. So right now, I think we are in that second phase so we had the hammer, which is the tough measures that were undertaken to restrict movement and close businesses, etc. Now with the easing off, we're in that down space, as it's known in Malaysia. However, although there's been some relaxation of the restriction in movements and some businesses have been allowed to reopen, we still need to remain vigilant because the risk to individuals in getting the infection remain. But the idea is to keep that, I think many of you would have heard about this R0, which is the reproductive rate, below 1. And in addition to that, expansion of testing, early diagnosis, contact tracing, quarantining and isolating of patients and close contacts will need to continue if we don't want to see further surge in infections that will then lead to to another episode of healthcare systems being overwhelmed and the need to have the lockdown again. So we do not want to see this yo-yo taking place, and therefore it's very important that individuals and communities continue with this prevention measures of physical distancing, masking, hand hygiene, etc. So next slide. So this is a graph showing, as I mentioned, there's huge heterogeneity in terms of where countries are with in the trajectory of the epidemic. And in terms of Malaysia, I believe we're in this dance phase rather than the, well, we sort of in between, I guess, between the lockdowns, the hammer, which has been taken off a little bit. And we really are in this dance phase where we need to, as I said, we need to continue with those behavioral interventions, the societal restrictions that should, where we aim to keep infection levels low and hopefully the reproduction rates to less than 1. From the presentations by the Director General of Health in Malaysia, our reproduction rate at the moment is less than 0.5, which is an excellent place to be. Next slide. So I borrowed this slide from a publication from the Chinese University of Hong Kong in the Lancet from a couple of weeks ago that looked at the public health measures and the public behavior changes, which they believe resulted in the limited spread of COVID-19 in Hong Kong, despite really being really next door to the epicenter of the original epicenter in Wuhan, China. So public health measures such as entry restrictions, travel restrictions, quarantine, physical distancing are all key in ensuring that we continue to have low levels of infection up until such time where a vaccine becomes available, or you've also all have heard about the herd immunity to get to, well, you know, numbers are debatable, but to at least 50%, and some experts would say we need to get as high as 80%. So as you can imagine, I think the changes that we have all experienced in the last few months, even if the Malaysian government continues to take its foot off the brake in terms of the movement control order, the individual and public behavioral changes will need to persist for a long time to come. And my colleague, Professor Altice, will give you some indication on the on when vaccines will become available as he discusses the development, the exciting development in vaccine from around the world. So next slide. In the next few minutes, I'll just discuss some local clinical data as well as clinical experience that we had at UMMC, the hospital I work at, which was one of the designated COVID-19 hospitals in Malaysia. In total, we saw just under 150 patients with confirmed COVID that we managed in the hospital. Right now, we have very few patients, thankfully, thanks to the overall low numbers of infection in the country. Next slide. So just very quickly to summarize the clinical manifestations of this disease. Next slide. As all of you may have heard, originally reports from China led many of us to believe that this is an illness that is predominantly a respiratory illness, much like the flu, but as more and more cases became known, it is clear that this disease, in terms of its transmissibility as well as its disease pattern, is different from that of the influenza virus. And now, 6 months into the epidemic, we know much more about the clinical pattern as well as the pathology that explains the clinical illness. We know that in the first phase of the illness, in the first week or so, the clinical manifestations are as a result of the direct viral infection and the viral response, and patients may present, well, many patients, up to 40% of patients, may have no symptoms at all. Of those who do develop symptoms, around 80% have very mild symptoms of fever, dry cough, but diarrhea and headache. Patients do describe intense fatigue and loss of appetite, and this seems to persist for some time. In about 20% of patients, 15% would develop what is known as the severe phase of the disease, and another 5% develop critical complications, often needing mechanical ventilation. And we now believe that this second half of the illness, the development of the complications, is as a result of the host inflammatory response. In the first week, as with all infections, when a foreign body, in this case the SARS-CoV-2, enters the mucosa and then into the bloodstream, the immune system kicks in and tries to overcome this foreign invader into our bodies. And in the majority of patients, the immune system is able to overcome this infection, and the patients recover. However, in that subset that I described earlier, who develop complications, for some reason, the immune system is not able to just overcome the infection and stops, but instead it goes into a hyperdrive mode and results in what is now known as the cytokine release syndrome or cytokine storm, that many believe is responsible for the complications that we see. Next slide. So here's another way of explaining it in terms of the proportion of patients who develop symptoms and those who develop critical illness and severe illness, and the types of complications that we see. So the most common severe complication is that of hypoxia, which is a lack of oxygen in the bloodstream, and what's known as acute respiratory distress syndrome, and the respiratory failure that necessitate mechanical ventilation. In a subset of patients, there's also complications that result in kidney failure, liver failure, and literally involvement in every system of the body. The cytokine release syndrome, in addition to causing this multi-organ failure, also leads to a hyperdrive of the coagulation pathway that leads to thrombosis, where there have been reports of strokes and a condition called pulmonary embolus, where you get clots, clots happening and being released into the lungs. So those are some things that are now being commonly described. And this is a picture, next slide, of the clots, that the microthrombosis or microclots that that clots up the small blood vessels in the toes and nails, that results in this appearance of the COVID digits. Next slide. So I just want to share with you in the last few slides of this phenomena of the cytokine release syndrome and the clinical trial that we're doing along with colleagues from the Ministry of Health and Professor Altice from Yale, to try and look for the best treatment to mitigate against this cytokine release syndrome. So in mid-March, a patient, 66-year-old gentleman who had been traveling, was referred to us after having been diagnosed as being COVID-19 positive or SARS-CoV-2 positive from a private hospital. As was the treatment advice in March, he was started on hydroxychloroquine and azithromycin because he belongs to a high-risk group by virtue of being over 65, slightly obese, and having diabetes and hypertension. He already, when he was admitted, was showing some signs of respiratory compromise with low oxygen measurement, as well as changes on his chest X-ray. Very quickly the next day, he desaturated, meaning his oxygenation became lower. And again, as was the clinical guidelines at the time, was changed to another antiviral called Calitra, and the azithromycin, an antibiotic, was continued. However, he worsened and was admitted to intensive care and needed further support with the high-flow nasal cannula. At this point, I very informally called Professor Altice, because this was when we were starting to hear of the huge number of cases that the United States was seeing, and I just wanted to know if Rick was managing very many patients at Yale in New Haven. And so I was sharing with him some of the patients that we were starting to see with respiratory failure, and described some of these patients that we had. And that was when the discussion to try tocilizumab, that was at that time, I think, New Haven, Rick, you had, I think, 20 patients on tocilizumab, and we thought that we had nothing to lose because the patients were getting very ill, and started this patient on tocilizumab on the 25th of March. You can see that his X-ray on the right bottom column there has whitened out as compared to his earlier X-ray on the 20th. And so he was given 1 dose of tocilizumab. In most patients, that's all you need. And to our surprise and relief, he improved the very next day, and needed far less oxygen support than he did the day before. Next slide, please. So subsequent to that, we then gave tocilizumab to 7 more patients, and out of the 8 in total who were given tocilizumab, 2 had severe respiratory failure at presentation, and had in fact already received mechanical ventilation by the time they were treated with the drug. 6 others were in a similar situation to the patient I described earlier. Out of the 6 who were given tocilizumab at, I would say, at an earlier stage, none of them progressed to needing mechanical ventilation. And one of the 2 who was given tocilizumab whilst already ventilated passed away. But the other patient has now been extubated and is doing very well, receiving rehabilitation prior to discharge. So with that impressive experience that we had with our 8 patients, and with further discussions and dialogue with Rick over at New Haven, we decided to the proof is in whether this drug works or not really needed to be shown in a randomized controlled trial, and this is what we have designed and planned, and in fact are ready to enroll patients comparing tocilizumab with corticosteroids, which is another drug that can be used, that has been used in the cytokine response syndrome. So we're very excited about this collaboration with Professor Altice and his colleagues in New Haven, along with our colleagues at the Ministry of Health, at Sungai Buloh Hospital, Hospital Seremban, as well as Hospital Kuala Lumpur, to test this hypothesis that tocilizumab versus corticosteroid is going to be effective in preventing patients with the cytokine storm syndrome from progressing to respiratory failure and needing mechanical ventilation. So on that note, I will pass the mic, as so to speak, to Rick. I think this is an illustration of how our 15-year or more collaboration has been absolutely vital, and in this case, life-saving to several patients. You know, we're really excited about this collaboration. In fact, I should give a plug to another collaboration that we recently have been funded to do an implementation science training in HIV for Malaysians, for academic staff at University of Malaya, as well as those who have enrolled in PhD to be trained in implementation science. So we're very excited about that. And I'll hand the mic over to Rick to expand further on clinical treatment and vaccine for COVID-19. Thank you.
Terima kasih, Adeeba, and thank you. And selamat pagi for those of you in Malaysia. It's really a pleasure to be here, and it's always a tough act to follow when Adeeba is presenting her work. And so let me just sort of walk you through at least some of the things that we have been sort of dealing with near the epicenter of the epidemic. And so whether you turn this right side up and think about this as an iceberg, we were typically focusing on what do we do at the tip of the iceberg. And as Adeeba said, most patients will just have some symptoms and they will never really progress. We do know, however, that increasingly there are a number of factors, many of which the patient that Adeeba presented had, that really increases their risk of progression. And so this is a special group of patients that we follow especially closely on the outpatient, and we try to do what we can in order to keep them from being hospitalized. But the tip of the iceberg is really those patients who do get into the hospital, who utilize hospital beds that are often restricted resources, and also they might move on to mechanical ventilation, which is another sort of restricted resource that we have in our hospital. And so what we really do is we focus on how to prevent severe outcomes. Adeeba talked about reducing death and reducing intubation in her patients. And so that is really early. And then as we begin to get better at those sorts of things, we then begin to sort of looking out further and trying to think about how to treat patients who are in the community. You saw this slide already, and I'm going to talk a little bit about how we think about some of the treatments. During the first phase of the disease, somebody who's early on and before they have severe symptoms that are associated with the shortness of breath and the abnormal chest x-rays and the pneumonia, we focus on this viral response. And so the agents that we might use for treatment would be in the viral class. Now, let me just say that right now, the international guidance is that there is not a single evidence-based treatment for COVID-19. And so what we typically do is we use the best information we have to try to save our patient's life, just like Adeeba just described for her cases there. And so we look at what might have some potential viability. We've got a handful of drugs such as chloroquine and hydroxychloroquine, some mixed results with that. In fact, in some cases, there have been some really adverse side effects. So there are some safety issues with this. Lopinavir ritonavir, which is an HIV medication that has been used, has been mostly removed. There are still clinical trials, but one smaller clinical trial from China showed that it really had no benefit whatsoever. And then we've recently had a signal from remdesivir. It was a drug that was developed for the treatment of Ebola. And interesting, a small single group study has shown some initial benefit. More recently, there's been a clinical trial. It did not improve survival. It just reduced the number of days spent in a hospital, which is still a good outcome. But we really don't have a signal that it actually stops the full onset of the disease. and better clinical trials are underway. Then, of course, the second phase, and the one that really probably causes the most of those things that are at the tip of the iceberg, which is this host inflammatory response, or what is sometimes known as the cytokine release syndrome, is probably the place that if you want to focus on in reducing patients going on to mechanical ventilation and from dying, is to really think about targeting that piece of the spectrum. And while there's no reason to go through this, these kinds of medications that are used to treat the cytokine release syndrome really fall into two categories. There are the very broad-based agents that actually treat really all of the cell lines that are associated with the disease. And there are some that I think that we call more surgical. They're more precise. They have fewer side effects, but they're ones that actually stop and arrest and potentially shut down at least part of the response. And interleukin-6 is one of the major pathways by which this goes. And there's a number of drugs that are currently being studied. So with regard to the broad generalizing effect on the entire immune system, glucocorticoids and convalescent plasma, that is the plasma from people who've been infected, they've already developed an immune response. And so putting that back in order to sort of halt that immune response are two of the broad spectrum strategies. There are some concerns around corticosteroids. We learned from SARS that the viral replication continued during that time period, and there was an increased risk of death. That doesn't seem to be quite as true. I think the pathophysiology for COVID-19 is different, so I think we're seeing some different. And in a number of these, what I call surgical precision agents that are interleukin-6 or JAK2 inhibitors, you don't need to memorize anything, but just to recognize that that is going to be part of the clinical future as we look for these clinical trials to finish and present from us. Let me tell a little bit about what happened. We're right near the epicenter. We're 100 kilometers from New York City, and we really were incredibly anxious as we were hearing from our colleagues in New York who were literally drowning in patients, and we knew that we were next. And we watched it march right up the Connecticut shoreline, and we did some projections looking at how soon after the epidemic hit would we actually hit our peak ventilator count. If you will. And so in the meantime, most of the things that we do in the community to flatten the curve, if you will, are done by social distancing. But for hospitals, you've got to do something to treat patients in order to flatten this curve for these mechanical ventilation beds. And this was the resource that we were focused on. What we did was we used a system-based approach, and this is about when Adeeba was contacting us. We wanted to really figure out how to reduce the mechanical ventilation rate and death in our patients. We got together a multidisciplinary team. We used a sort of a collaborative learning response, and we really focused on things that might have the most impact. We ended up selecting tocilizumab. It lasts for 14 to 17 days, so it saves patients through a longer period of time, and it actually has very few side effects. And so we targeted that. And then we also did a number of things that we're focusing on really helping take care of our healthcare workers and their families, and put in place a number of strategies to really make sure that that was safe. And we moved almost everything quickly to taking physicians out of the hospital, except for the limited few, and to doing most of our consults using telemedicine. So what ended up happening is that the flattening of the curve for patients coming into the hospital didn't happen until several weeks into the epidemic. And in blue, you see the total number of patients in our census. We got up to 450 patients in our hospital wards. We're down at about 250 to 300 right now. So we're coming down off this curve. So you can see that this is what happened as there was no flattening of the curve for hospitalization. But if you take a look at what happened as we used tocilizumab to treat specifically the cytokine release storm, you see that we flattened out the ventilator effect very quickly, and we never really got into trouble during this. And of course, this is basically two things that were going on, but we really believe the tocilizumab had an impact. And when the other sort of thing that we were looking to be able to do is, did it have an impact on death? We look at many different published studies from China, from Western Europe, from North America. It hit Seattle first. And you can see these rates are in the 25 to 35, even 40% rate in terms of mortality. But if you look among our patients overall, it was about 10%. And for the patients with severe disease, these are the ones that are right on the verge of mechanical ventilation. The mortality rate was only 14%. So we think that we really flattened the curve with regard to mortality, but also mechanical ventilation beds. Now, as Adeeba said, that the way that she presented the case was exactly what we see. It reduces the days on mechanical ventilation. Survival goes up to 75%. Most patients who get mechanically ventilated, the mortality rate is 50 to 90%. That is, most of our patients do not get off. So it essentially was what I call an equalizer with regard to saving patients who were transitioning to a very, very danger zone with regard to that. Now, the one thing that I think that we're going to have to think about as part of that future dance is, and we're going to have a lot of dancing to do as microepidemics, but we have to really think about how do we continue to bend the curve? And of course, as we begin to relax these shelter-in-place strategies, we're going to make sure that we have that combined with that. Recommendations by WHO, which include really marked increased testing, identifying those cases, and then doing contact tracing and isolation of those individuals while we're waiting to be able to sort of implement a wide-scale vaccination. So if we want to think about it, all of the rest of the earlier part of my presentation was focused on the patients who were hospitalized. But really, if you want to flatten that curve, if you will, bend that curve of hospitalization, you have to begin to work in the community. So these social distancing things are what's done here. And these are individuals who are at risk for the disease. We know that there are going to be individuals who will get infected, and we hope, but we're not sure, will actually develop some level of immunity and to begin to protect it. But a handful of cases, 5-10%, is not going to be a sufficient amount in order to provide enough immunity to protect people, so that as you begin to relax these things, a single outbreak could actually start to have micro outbreaks in a number of places. And then what we ultimately want to do is we want to replace these individuals who are really at risk with those who are vaccinated, that is protected, recognizing that a vaccine may not be perfect. Currently, there are 115 vaccines who are at some stage of development. Most of it is in the sort of the early exploratory phases or preclinical phases. We're finding information, but there are 5 that have hit the clinical development phase. 2 days ago, there was big news that 8 cases, patients who were treated with the Moderna RNA vaccine, actually they found a safety signal and they produced antibody. Now, whether that antibody is effective at preventing infections, we don't know, but we've got 5 good candidates that seem to be coming down the pike with regard to phase 1 studies. And so some of that early work that we get very anxious about getting done is at least starting to show something. One of the things that's going to impact the development and the ultimate distribution of a vaccine is thinking about how that this is being done. So nearly half the vaccines are being developed in North America, and an equal portion of about 1/6 of the patients are being produced, or not patients, but vaccines are being produced in China, Europe, and then elsewhere within Asia and Australia. And one of the things that's important to recognize is that nearly all of these are being done in the private industry. So there are going to be profit factors which are justifiable, but that may actually limit the availability of a vaccine depending upon what the pricing market is, whereas if it were public or otherwise, that could be controlled much better. What do we want with a vaccine is, of course, we want a silver bullet, that is one that is 100% safe, that is, it causes no side effects, but we also want something that works, and we call that word efficacy. And it needs to be able to substantially prevent infection. The phases are phase 1, which is the safety. This is like the Moderna vaccine, about 10 patients or so, where we find the lowest dose required to produce the maximum antibody, that is immune response, in healthy volunteers. Phase 2 involves patients in the hundreds, and we ask the question, how well is that vaccine working in those who need it? For instance, the elderly, the ones with hypertension, etc. And you really have to test it across a wide group of individuals who are at risk. That include children. And we're seeing, at least early, we thought that there was really no problem with children. We're seeing PIMS, which is this hyper-inflammatory syndrome in children, which is really quite devastating. And we're seeing a fair amount of that now. And then phase 3 is the classic randomized controlled trial that will take thousands of patients. And it really asks the question, for those who get exposed, is there a reduction in the likelihood of getting infected, and how much of a reduction is there. And then once that happens, there is the process of getting manufacturers to produce it. So you've got to have a bunch of places that are ready to go and ramp it up in multiple places around the world. And you have to go through the regulatory documents in order to get approval. So what we know from the history of vaccine studies is that the fastest vaccine that we've ever developed has been done in 5 years. That is not the kind of time that we have right now to move from phase 1 all the way to licensing, wide-scale manufacturing. And then, of course, we've got to do the implementation. We've got to get it to the people who need it. What is happening with this truncated response is trying to get this done in 18 months. We have fantasies that it will happen in this fast, but there's a number of things that have to take place. Things have got to be moved quickly, but we can't also do it and have something that is relatively unsafe that's not going to work, and we're going to have to shorten the licensing period. And then, of course, the other thing is governments across the world are going to have to behave in terms of their own approvals once we get something, because we've got to get this out to 7 billion people around the globe if we sort of really want to focus on everyone. What do we need to know? The experts who've done the modeling says that if we can get a vaccine that will prevent 70% of the infections, it's likely to be enough to stop the outbreak. But if it's 60%, it will contain it. But we're still going to see some localized outbreaks. And if it's less than 60%, we're really going to be unlikely to establish herd immunity. That is, we're going to have enough people protected that even if you have an outbreak, the people around them are going to be protected. There are some really important issues because this disease impacts more negatively those individuals who are older and who have immune compromise. Will we have to use higher doses? Will it work in them? Will we have to use boosters? And we certainly know that vaccines like varicella vaccine for shingles required in elderly folks oftentimes a higher dose and in some cases a booster in order to establish some kind of immunity. We know with things like hepatitis B that it requires multiple doses, these boosters. So how many will it be? And the more doses that you have, the harder it is to get people back in order to revaccinate them. And then the other questions that we have, like for instance, with influenza, it lasts a season if it works at all. And even the influenza vaccine from this past year was only 45% effective. So how long does that immunity last? Is it going to last one season? And then do we have to create a new one in the following years? All things that are unknown. And if we develop an antibody, is that antibody going to actually be protective? The other sort of thing that we really have to be thinking ahead about is that most vaccines that we get for most common conditions, we can store in our refrigerators at home. And so we're able to get it out to many places all over the globe, including in equatorial regions. The problem is that our experience with most RNA vaccines, which this will be most likely, will have to be stored at incredibly low levels, minus 80 degrees, which are typically research freezers, and it will be inaccessible for much of the world. So that's a major sort of issue. And then, of course, I would say we have to really think about prioritizing who gets it first. And so if you happen to be from a high-income country and you happen to, have access to money and you can get what you want, you're going to want to take care of yourself first. However, the places that will be most devastated will be the low and middle income countries where there's a lack of hospital beds and a lack of medical infrastructure to take care of people who get sick. And so maybe perhaps the calculus needs to look very different, which is why I go back to the issue about who's producing it and what will the costs ultimately be. This has been a long, strange trip for me. As Jerry Garcia from the Grateful Dead said years ago, I sort of cut my teeth on the HIV epidemic, and it has been an enduring epidemic for which we have really seen major breakthroughs, but we are still combating it on a day-by-day basis. This is unlike that epidemic in so many ways. The ability to contain it, the way that we even interact with our patients, not being able to sort of have a direct communication, separating ourselves with telemedicine, wearing protective equipment. It is very, very different, and a casual contact for some of us could be deadly. And so it's a very different calculus. When I think about the HIV epidemic, and I went back and reread it again as I started taking care of COVID-19 patients, I diagnosed the first case and I ran the first 6 or 8 weeks of our services for COVID at Yale New Haven Hospital. I go back to The Plague by Albert Camus. And there's some really important things to sort of that are uplifting about this. And I was on sabbatical. In fact, I was 2 days away from going to visit Prof Adeeba in Malaysia, and my wings were clipped, and the university said no international travel. And they said, Rick, you're coming back to help us with this problem because we don't know what to do. And so the one thing that happened is nothing in the world is worth turning one's back on than what one loves. And I think Adeeba and I both would echo the fact that we love taking care of patients and we love making a difference. And I think we've had a chance to do that. As I started the first few days on service, I thought to myself, I have no idea what's awaiting me or what will happen when all this ends. For the moment, I know this, there are sick people and they need curing. And what one does is roll up their sleeve and they take care of those needs. And they often don't take care of other needs, such as working 16 hours a day and all of those other sorts of things. And then as I was watching my colleagues and watching the news and everything sort of furling around, this quote sort of spoke to me. There are more things to admire in men, and I added, and women, than to despise, because I saw incredible people who were stepping forward to really make a difference. And almost in no place in the world are healthcare workers ever considered heroes. And this is exactly what our colleagues have done, is they have stepped forward and become the sort of the 2020 heroes, if you will. And then as the numbers of patients burgeoned, 450 patients at our hospital was huge. And what I can say about that is what's true of all evils in the world is true of plague, in this case, COVID-19 as well. It helps men and women rise above themselves, because that is exactly what happened. And I will say that every morning when I get up, this quote stands out to me. I was very fond of you, but now I'm so tired. I'm not happy to go, but one needn't be happy to make another start, sort of recognizing that even though you just finished a 16-hour day, you got up and you did it again because there were people who needed your help. I will say that watching heroes in place has been one of the things that I've been able to admire through my relationship with Adeeba over the last 15 years. We have celebrated a number of things. This is the first big grant that we did working in the prisons. Harapan means hope, and it is a word that I have great promise for right now, Harapan. And I will say that the other sort of beautiful thing about this, and the beautiful thing that we're sort of seeing happening with COVID, is that we have had the opportunity to train and to work with a sort of a rainbow coalition of really wonderful trainees and scholars and experts and really committed people. And I have to say that this is the one thing that gets me up each and every morning to be able to make a difference. Terima kasih, and thank you.
Thank you so much, Professor Altice and Prof Adeeba, for the information and the engaging talk. We're going to look at some questions on Facebook that have come in through the comments. And so maybe the first question I would like to direct towards Professor Altice would be, looking back at the initial response in Malaysia towards the outbreak, do you think that our response was timely? And if so, if there could have been any specific improvements or things that we could have done better, and would those sort of improvements or adjustments have a better outcome for us with less restrictions on the general public?
So I'll say a couple of things. First of all, the one thing that Malaysia does really well all the time with is draconian measures. They act quickly. Sometimes it seems like it's an over-exaggeration. In this case, they got it just right. They moved on this very quickly. They stopped people from coming in. They put in quarantine. I mean, had I arrived 2 days later, I probably would not have gotten out of there so easily. So I think that that is really important. I think that they did very, very well and did so very early. And that is really a testament to early intervention, which did not happen in many other places in the world. And then the other thing that I think is that, could something else have been done differently? I think, for instance, this large religious gathering that came together with thousands upon thousands of people, which was your big mini cluster, you would have really almost no epidemic whatsoever had it not been for that. It would have been imported cases, and it would not have really had that sort of thing had these large group things not happened. So I have to say that I think Malaysia has done a really stellar job, and they're ready to dance. We're ready to get hammered, and Malaysia is ready to dance.
Prof Adeeba, do you have any further comments on this?
No, I think I echo what Rick said. I think the easy part is the the general restriction, but as we know, it has a lot of economic and social economic impact, and the question now is, can we be a bit more nuanced in terms of the restrictions? Can we, rather than have a nationwide restriction, can we look at our data in a lot more detail, and perhaps have very strict restrictions in places where you are seeing a increasing number of new cases? That's one. And secondly, I think we also need to expand our ability to test and diagnose early. DG has announced that, but we really need to get each and every general practitioner tuned to the possibility of COVID-19 in a patient who fronts up at their clinic, and be able to take steps to diagnose, contain, isolate, etc., etc. I think that until such time when we get the vaccine, that's what we will need to do.
Thank you so much for your responses. Professor Adeeba, we have a question that's directed towards you. There's been a question that's come up in the comments asking if there are any predictions on the number of daily cases post Hari Raya, as now, home visits are allowed and they're allowed to have 20 people in a house together. Do we sort of predict that there would be an increase in the number of active cases every day?
Yeah, so I haven't seen any specific, modeling to give you an exact number, but that certainly is the worry, because as Rick said, one infection could very quickly multiply. If you take the fact that we are at our reproductive rate is 1 or less than 1, then hopefully we won't see as many waves, but it all remains to be seen how people behave in the next few weeks. Remembering that the outbreak in Wuhan was also associated or around the time of Chinese New Year, where there was a lot of travel. So it's not just the visiting to individual houses, but also the being in crowded places such as bus terminals and public places where a lot of people gather, and fomites are contaminated.
And it's I'll also add that I think it's really important for people to create social circles that are somewhat limited. So if you have 10 people in a group today and a different 10 people, or at least half of them change, every time you change that is the movement of people. And so let's say, for instance, if you are going to celebrate Hari Raya, if you could have a consistent group of people who are coming back on a day-by-day basis in order to limit these larger networks, that will have the greatest impact if you should have an outbreak.
Thank you. A next question that we have is a person who's asking about the growing number of relapse cases. So in South Korea, where patients who have recovered and are testing positive again, is this due to a viral mutation, or what is the actual cause of this sort of relapse, so to say?
I can take that question, Rick. Actually, this is not a relapse, but what we now know is there is continuous detection of the PCR in a certain proportion of patients. In Wuhan, in China, it's estimated to be around 10% of people where you can detect this PCR in a number of cases, even as long as 60 days from the time of infection. It has in not an insignificant number of people, it's been detected a month after infection, and we certainly see this in our own patients as well. However, when these viral particles are then cultured, they've not been able to show that these are still live viruses, so to speak. So the current understanding is that these are particles that can be detected by PCR, but they don't represent active viruses, if you like, and do not mean that the patients are still infected. The current thinking is that the ability to transmit really falls off from a patient who's infected after about the first week of them being positive.
I will say that was a painful lesson that we learned here at Yale. We were using that to guide our discharge, and we had patients who we could never get out of the hospital because we had dead virus, but the PCR will still remain positive. So it looks like they have the infection, but it's just dead virus.
We've had a comment/question coming in that says that there's some sort of public health messaging gap between urban and rural communities in Malaysia. And so, because, Malaysia is a very diverse country, we have lots of different groups of people. How can we sort of improve the effectiveness of the messaging to the public? Because many people are still unaware about the importance of hand washing and using hand sanitizers. And also they're wearing gloves, but they're cross-contaminating by touching different items. What can we do, like not only the Ministry of Health, but also at the community level, at the individual level, to sort of disseminate information amongst the general public?
So I think this is where we can learn from the 4 decades of the HIV epidemic. Where HIV has really excelled is in working with communities. And it's super important, not just to be giving messages. And I'm actually very impressed with the messages that we see on TV, for instance, and on radio. But we really need to, as you said, we really need to get down to the ground. And Malaysia has this system of Ketua Kampung and, at the state levels, at the daerah level, at the kampung level, where we should be engaging a lot more effectively and in lingos and languages that are specific to that area. The other important group that we mustn't forget are the foreign workers, documented and undocumented migrants. And again, working with their own community, peer-to-peer education is going to be key.
Thank you. So in case of Malaysia, how are we sort of contributing to the research globally? Are we utilizing any sort of genomics approach towards COVID-19 and epidemiology and community surveillance?
Yeah, so my own colleagues in the lab are doing some sequencing, and I believe other labs around Malaysia are also sequencing the viruses that have been isolated or from the PCRs and contributing it to large global databases. Firstly, to detect any any new mutations which are going to be important in terms of current and future vaccine designs, and the sequencing will also be very important in terms of understanding the molecular epidemiology, the networks of infections that are currently occurring. So certainly my lab is doing all that currently, and because one of the good things about this COVID-19 outbreak is there's been a huge international solidarity and cooperation and collaboration in research, and people are putting in their genome sequences in large databases that can be accessed all over the world. So that's from a molecular epidemiology, molecular understanding of the virus. But Ministry of Health is also involved in the Solidarity clinical trial that WHO has launched. And that's to look at the different treatment options, remdesivir and Kaletra, as well as hydroxychloroquine. We opted not to take part in that, we meaning UMMC. And finally, of course, hopefully, if we get going with the STORM trial, the study design is a little different from others that involve tocilizumab. We're comparing it with corticosteroid. Tocilizumab is a rather costly drug and may not be, if it's shown to, if it's proven to work, may not be accessible for the entire world. Corticosteroid is an interesting option. And so if we get going with the study and show one or the other or both work, I think that will be a very important contribution to the treatment armamentarium, especially for those with severe disease and cytokine storm syndrome.
So maybe one final question before we wrap up. Do we sort of, in an ideal world, everyone would be vaccinated and sort of like sort of immune to this virus? And how long would it sort of take us to achieve this sort of ideal scenario where everyone's vaccinated and we're all protected? I know this is probably a little bit a long-term question, but like, any comments on that?
Over
Sure.
to you, Rick.
I was gonna say I have a lot of them. So, every bit of the questions that you're asking are going to boil down to which vaccine we select, how effective it is, how many boosters, what are the doses, and does it produce short-term or long-term gains? And that's going to be, all of those are going to be big-time game changers. And if you can even get something that is short-term that will work long enough to flatten this curve so that the R naught, goes down to incredibly low levels so that there's only an occasional outbreak, then that may be sufficient. But think about getting a vaccine into 7 billion people around the planet. Let's just say half of that, 3.5 billion people. That kind of magnitude from an implementation science perspective is going to be huge. And one of the things that a very dear colleague who passed away said with HIV, and it had to do with how do you get antiretroviral therapy to the most distant villages in sub-Saharan Africa, and his response is, it's easy. If Coca-Cola can get a can of Coke into the hands of everyone on the planet, why can we not get a vaccine? And we're going to have to think like these big businesses and have implementation and chain supplies and people in the field who are lay workers who are doing this work. It is going to be huge, but it's going to require a huge investment of money and time and political will.
Thank you so much, Prof Adeeba and Prof Altice, for this really engaging and informative talk on COVID-19 and what we can expect in the following days to come. It was a really great session, which I enjoyed, and I'm sure many people who joined in learned something new. Thank you, everyone, for your questions on Facebook. And I would now like to hand it over to Catherine, who has some closing remarks before we end this broadcast.
Thanks so much, Dr. Collins. And thank you to all three of you, Dr. Collins, and especially Professor Adeeba and Professor Rick Altice from Connecticut to join us for this program. It was such an honor to have your expertise shared with our audience today. And it really was an educational presentation, and there are many more questions left unanswered, as we all know. So on that point, we will be posting this talk to our Facebook page for continued discussion, and please continue to post your questions, and we will try to find answers to the best of our ability. So I'd like to thank you all for tuning in and hope that you've found this talk in our series useful to you and beneficial. And I hope to see you again here for another session of a virtual talk by the U.S. Embassy, Kuala Lumpur. Jumpa lagi.